Hey guys, just like Vicky, if you don't know who I am, then there's no point knowing any further. But these are some reflections on the last few years of being here. And yeah, I guess it's always a time where we're thinking about our experience holistically, and so you see the growth and the change we've made in our lives since starting residency. So that's kind of cool. So this is sort of an outline of my talk. It's going to be a little bit rambly since I worked overnight, but we'll kind of go through these things kind of step by step. Guiding principle at kind of like referencing just the general goal that I think drives me and also all of us really here. We'll talk about some like personal quality improvement, like personal self-improvement at work. And I pulled a lot of attendings about like how they deal with like difficult cases and like their perspective on like how to like improve and kind of overcome like challenging situations. And then we'll end with some like cases that I found to be challenging, things that I took away from it, and then conclusions basically. There's this quote that this like super zen liver transplant surgeon, which sounds like a huge oxymoron, because it definitely is. But like he said this to me like when I was on a rotation my third year, like meeting like 4 other students. But he told us that we owed it to our patients to be the best we can be, and I think that statement's really stuck with me since then. Basically, I use that as like a tenet to guide me when I filled out my match list. I think I've returned to this principle during probably the most challenging moments over the course of residency. And you know, as you look back on like whatever it is, I think that this principle has brought me to a place where I was, I think, hoping to be basically. And so you acknowledge the shortcomings and the challenges of working at a place like Kings County and downstate, but it's a really unique place to learn to be a doctor. And we all chose to come here because we're really allowed to advocate for and do a lot for our patients. And so this means practicing medicine in a way that's unencumbered by many non-evidence-based metrics, where we can move towards what we think is like a diagnostic truth. And this is because our job is to do right for our patients and for this community. And so the broader idea about why we come to work is that we want to be the best doctor, the best person we can be. And I think this does guide us to some degree every day, right? There's a whole industry that's devoted to like self-improvement, self-help, and this attempts to mediate how we should live our lives. From like me kind of perusing books, looking at literature, speaking to like various people who are like on this journey of self-discovery, whatever that is. I've kind of informally narrowed this down to like 2 important facets for myself when I think about becoming like my best version of myself at work. And so the first thing it kind of starts off with is with deliberate practice. I don't know if you guys know the distinction between deliberate practice versus just like regular practice, but deliberate kind of practice is defined as being work that's purposeful and systematic, whereas regular practice is sort of mindless repetition. And so this is like a distinction because you're doing focused work and it's conducted with you moving towards a specific goal of improving your performance. And so the idea is that you establish reachable and specific goals. You focus on improvement, during work when you're supplementing your education, whatever that means. You get feedback on your performance. And then the most important thing really is that you have to get out of your comfort zone and you're constantly attempting things that are out of your reach. And I think that's pretty straightforward because this is kind of what we do on a day-to-day basis, right? You read to build your knowledge base. You see as many patients as you can to develop your heuristics. You model yourself after attendings in the way that you see yourself wanting to practice. And then you fundamentally work on and master like all the skills that you think you need, right? Communication, procedural, diagnostic. And this it feels kind of effortful in a way, but I think it's pretty linear and like you kind of see the progress you make pretty clearly. You get what you put in basically. And I think like to kind of piggyback off of that, probably one of the best pieces of advice that I got was from former attending of ours. He was a county grad, Jan. I think he was here for like our intern year, maybe into our second year. So some of you guys might have run into him, but he was a big proponent of doing your own personal quality review, which essentially for him, he told me this when I was like an intern at downstate. And he was like, at the end of each week, what you should be doing is you should be following up every single admitted patient you have and then reading about, bounce backs. So he told me to buy this bounce back book. So I bought the book, I haven't read it yet, but I do follow up my patients. And this gets more and more difficult with like the more patients you see, especially as an attending, but I think it's like really, really good for you and like your personal growth as like as a doctor basically. because you learn what you missed. You kind of figure out what the general workup is for these patients, right? Inpatient, and then you can kind of get a sense of like whether it's even relevant to admit a patient or not, like what's actually beneficial for this admission. You realize better who like can decompensate quickly, and then the whole point of this is kind of building your heuristics essentially, right? And so obviously you definitely improve and correct mistakes, you know, that you were making in the past if you're like diligent about this. But it also goes without saying that once you kind of like start doing this, you notice that you miss things, and then you see that patients do, you know, decompensate, and they do get worse, whether it's because of you or because of the hospital around you. And that can kind of take a toll on you. And I think what I'm more interested in beyond like the deliberate practice kind of methodology is just like the introspection that we do after like challenging cases. And to me, this is like the really hard part about like your growth, right? It's a very reflective process. It can be pretty agonizing if you have like bad cases, and it can take a lot of time. And, you know, like this involves like self-reflection about your performance. It makes you think about how you cope with these outcomes, right? Like psychologically, intellectually, at shifts, at home. Like how are you processing like how you want to change your practice patterns after you like really messed up, or you think you messed up? And then like probably the most difficult thing is how do you rebuild your confidence in like yourself as like a person, like your heuristics, and you know, what is this new like normal that you create for yourselves, right? So like with bad outcomes, you're confronting, you know, a lot of different like insecurities, right? Maybe you think you didn't know enough, so you need to study and review. Maybe you felt your execution didn't really match like the knowledge base that you developed, right? Or maybe you question your leadership or your sense of self, right? And a huge part of this is like you're kind of re-experiencing this trauma. And so I think like since we've been here as residents, like I think everyone can hear that second victim term thrown out quite a bit. But it's relevant because, you know, you start thinking about all these anxieties and like deep insecurities that you have. And so the doubt can become pretty pervasive, I feel like. And to me, like being able to contextualize this and come out with a sense of humility, but also like still a strong sense of self, like that's the true curriculum of residency. And this is kind of like the lifelong learning you need to be doing as an attending, basically. I talked to Matt Racinci a lot, like while I was kind of making this lecture, and he conveyed to me that this is sort of the essence to him also of emergency medicine, where it's like, you know, through repeated mistakes and like iterative successes, that's how we generate a way to care for patients fundamentally and for yourself too. And so having done like M&M the past year, like doing peer review, which I think all these things are really helpful, I become really interested in kind of thinking about how different providers like kind of go through these processes themselves. And especially as like, you know, going to be a new attending, like the nerves are really kicking in. I don't know if you guys have seen this movie. It's pretty good, actually. I watched it on a plane, which is like a funny place to watch it. But yeah, but like, you know, you're like entering this like new part of your career. So you're feeling kind of anxious. You know, we're living in this like capitalist dystopia. Everything's kind of like coming to an end. How do we cope? And one option really is drinking, right? Like, I think Vicky talked about this too. And so like maybe our 18 hallway patients, they're on to something. Maybe. This is a still from Another Round, which it's this like Danish movie that was released like last year. It's better known in its Danish poster as Drunk. And it's a really good like movie. It's like a slow burn of like a film. Follows these 4 high school teachers. They're all best friends. They go through their like midlife crisis. Like life's kind of boring. They're all depressed. They're lacking inspiration. And it's one of their friends' 40th birthdays. And so this guy is just like, I've been reading this like, you know, philosopher Kierkegaard. And he proposed this idea that humans are born with a 0.05% deficit in their blood alcohol concentration. So filling this deficit will make you more creative and relaxed. And so what these guys end up committing to is that they can only drink during the day at work. You don't drink at the night, you don't drink on the weekends. And you're supposed to see this like fundamental change in like how you like live your life and, you know, behave in the world, which like initially in the movie, like they actually do get better as people, right? Like they kind of like release their anxieties. Because they're all very anxious people in like different ways. And I think like this is where the director introduces Kierkegaard, who's this like existential philosopher basically. He introduces this concept of anxiety. That's like I don't know how to say that actually, but that's the actual like term that he it's like the name of the work basically, Begrebet Angst. And the thesis of this like piece is that in order for you to like, love life, kind of accept others, you need to accept yourself to be fallible. And I think those, that as a principle maybe is the biggest thing to like accept here, right? Maybe like accepting your anxiety, accepting yourselves, and not losing yourself in this whole process. Like that's the move to like handle all these really difficult situations that you're in. Like all the death that we see, insecurities that we have about like missing cases, not being able to do procedures, et cetera, right? So like you try to move on, right? You change your scrubs after you caught the baby in the Uber outside the downstate ED, like the entrance, but you go back inside and then, you don't have scrub access. So what are you gonna do? You rely on others when you're on the ground, right? To pick you up. But it's like day one of ATLS. It's like 5 more days. You're at Harlem Hospital. Like, when is this shit gonna end? Like, who knows? And then maybe you're on vacation now, so you go to some island because you're trying to rise above it all, right? On like a water jet ski like contraption. But then you feel like an absolute douchebag. It's like the coral reefs are dying. Like climate change is like happening, right? So like all this stuff is like easier said than done, right? How do we get through all these stages? And so like who better to ask than like our attendings who've gone through all these kind of difficulties at different stages in their lives, right? And they have a lot to say and a lot to share. And so like I sent like an email out to like the faculty, and like a lot of people give me a lot of really interesting things. And so I'm sharing like some of these themes and insights basically. And everyone feels really messed up by like these difficult cases. So let me, I guess I kind of like read those things. I know it's a little bit small, but I think it's important for all of us to acknowledge that the work is very difficult and the trauma that we carry is its own like beast. And I really appreciate the candor and vulnerability that people kind of demonstrated with their responses. And so this kind of goes in hand with this like second victim phenomenon, where it's like you recognize that healthcare providers who face unexpected patient outcomes or acknowledged errors, they're also victimized by the event itself. People write about it as like the quote unquote darkest hour of one's professional career. And this may become like a life and career altering event that produces permanent consequences, whether it's like good or bad, right? And people kind of like talked about different things too. Like this takes a huge toll on us. People resonate with like different kind of like patient encounters, right? Like say you see yourself in people, you see your family and like the people you're taking care of. Whether it's like the young, healthy people that you've reassured to family, especially. That was like a running theme of like when it was like really difficult to like face yourself after like people died or people didn't really do very well, or like you missed something basically. And like this notion that like, we're at Kings County and we do hard work, but like, there's this pervasive myth in the community that like, well, myth, reality, whatever you want to call it, but like, you brought your family to Kings County and they died, right? And so like, we're all kind of counteracting against these narratives, but it's hard to like deal with all this stuff. And, the impact of all these errors on like physicians' lives, like it's pretty straightforward, right? Like you get really anxious, your satisfaction like diminishes, and like, there's harm to like your reputation, harm to your sense of self, all these things. And you can see the impact kind of in person too. This extends to residents as well, obviously, right? And it's no surprise that we develop this derealization, we take this home as well. And so like, whether it's like just being more burnt out, like not being as empathetic, just being more depressed, really. There's like a progression after like having an adverse event that seems to be pretty standard. Although like there's no one pattern for everyone, right? Because people are different, they go through stages, they move through it in different ways. Some people remain stuck in a stage for a long time. And like that to me is kind of like concerning, because how you see certain attendings and they just like are fixated on like the case that just really mess with them. And like every single time you see that patient, like it's this colossal workup, and like it's negative to you, but like, in their minds, they're reliving this kind of experience they had where, it's pretty catastrophic, right? And so like, ideally, like, based on your previous experiences, the support that's available to you, and like various response factors that you have, right? Like this defines your trajectory to like kind of like rise and move past the actual sense of loss, of self-esteem, of reputation, whatever stability that you had before, now that's kind of like magnified, but you want to kind of like move against it. And so a lot of people kind of talked about, like you treat everyone as if they missed they have that misdiagnosis. And I think it's like a general consensus that's pretty healthy for like a certain period of time, because like you're really conscious and you care for the patients, right? And so you're being vigilant. It's a sign of humility, but there's also a constructive way to like do this as well. So it was good to see that like people also had different perspectives highlighted, that you don't have to be like a terrified pain scanning machine all the time. But these are generally senior attendings who've had just like, they've seen more patients, they have this reassurance about like their clinical skills and their clinical sense of self. And so, like it's always like a question of how much do you change your practice pattern. I think if you're early on, like this might be something that like really shapes you in a way where you have to like think about how you get back to a normal. But like others who've kind of like, if they feel comfortable with like the pathology and all these things, right? Like you don't make drastic changes to how you take care of patients, right? Like you don't shy away from mistakes. Like these are part of you, like the last person said. And so you always are conscious of like what you missed or messed up. But that to me seems like maybe like a healthier approach. Although it's hard to say, right? Like we've all kind of had our bad cases. And I think a big part of this is because we change our practice pattern because we naturally tense up and feel anxious when our case goes to like a review, whether it's like an M&M or an RCA. And a huge part of this is just like the blame and shame culture that exists in medicine, whether it's present in front of our peers, getting grilled about decisions and actions, right? Or even like we think about this happening to us. And so M&M, as we understand it, is a tradition that's born out of toxic culture and surgery, basically. It started actually in the early 1900s because there was no sense of like patient safety or accountability. And so this guy named Codman, surgeon at like Mass Gen, he started like M&M there, and he made the surgeons present their cases and like the outcomes and complications from his peers. But I think what we know of M&M, I think like in our general sense, is like the 1980s when like it became kind of like canonized in surgical culture, where you're standing in front of like your peers and like you're getting grilled about like how you like messed up on a case or whatever. Nowadays there's like more of a shift to like this being less of a blame issue, more of like a patient safety concern. And so people try making it like anonymous presenters, make it a focus on like culture of safety, right? Like things you can change. There's no strong correlation between like anonymity and then the M&M is less punitive, but about half of all EM residencies use anonymize like M&M as like their education structure. And so, all these questions, right? Like, do people actually learn from their mistakes? But in a culture that's very defensive and like fearful, like not really. So like, there's a huge percentage of people who don't disclose their mistakes. Many people don't disclose their mistakes to families. And also if like you're working in like an institution where you feel like it's very like judgmental or vengeful, then you're not going to be as comfortable doing this either. And I think it's also defined by just like the relationships that you have with other departments, the administration, like the C-suite in the hospital. It can feel very punitive, and so like this leads to this culture of being very cannibalistic and like being critical of outcomes. So another attending also kind of said this too. The goal, however, I think is to be educational. And Peter Rosen is like a controversial figure, obviously, in our field. But I think this is like a relevant point. And Racinti talked about how M&M is at Denver Health, where he works currently. And so there, it's not anonymous. You present to a room of like 100 people, faculty, staff, all those things. And like initially, it feels like, maybe this is kind of like re-traumatizing. It's kind of brutal. Like, why did or didn't you do this? Were you not aware of these problems, right? Like, and I think it's a strong way to build like knowledge base. Yeah.
I just think it's really important for the faculty and you guys will be faculty relative to talk about the mistakes you made when you're doing the procedure, or that you made in practice when you have similar cases, because it makes the residents feel like anybody can do it, especially if it's faculty that they think are good faculty. And then it also prevents them from making the same mistake. Hopefully, it's much better for the residents to learn from mistakes that were already made and make their own mistakes. And I think that it's really important for faculty to own up to what they did wrong and to present it to the residents and see that it's there.
Yeah. He highlighted that too, where it's like initially like there's this feeling of like, okay, maybe it's like really punitive and like you kind of feel like you're out on a limb, like talking about your case and trying to defend it. But faculty also talk about like things that they've sort of like had difficulty with, that they messed up in, this is how they improved. And so in a way that actually builds camaraderie. And so that's like the goal here, actually. It's education, like patient safety, fundamentally.
Some people say an expert is somebody who's made every mistake in one field.
Yeah. Yeah, and so mistakes are part of the process too, right? And so you learn through a series of considerations, questions, And like these mistakes, the indecision that you like go through, I think that becomes, that might maybe normalize some of our worst outcomes, I think, mentally speaking. And so the goal, in EM is to do the best you can by your patients and by the society that you're in like the worst moments of people's lives, right? And so the process by which you figure this out under any given circumstance, I think this is the process of making mistakes over and over again, but like less catastrophically. There's never one right answer, but I mean, there are definitely many wrong answers. Another thing that was kind of interesting was that a lot of people talked about like the cognitive bandwidth that you need to have to like work a shift as an attending. And the clarity that you have at the start of the shift is not necessarily the same thing you have at the end of the shift. And it can be really exhausting. And I think like it takes someone to be very comfortable with themselves to realize that like it's okay to sign some patients out to the fresh team. It's actually okay to like step back when you feel like you don't really know what the workup is going, or you're just like ordering imaging, or like you're kind of like pushing to dispo a patient when like you don't have a clear idea of what like the appropriate diagnostic or therapeutic pathway is. And so it's totally okay to like, be humble about this and do this. And then I think it goes also in line with like assessing like, the risks and benefits of interventions that aren't benign necessarily. And this is like a little vignette that an attending kind of like gave me as well, where I think it's like thinking about like these things analytically and like in a more like sort of longitudinal way, rather than just in reflexively thinking, okay, this patient has like a massive PE and like, or submassive PE, like let's give TPA. Obviously that's like, there are pros and cons to doing things. And the situation is you have to be there, but it was like a valuable point, right? It's like you lose, your family, someone grows up without like a mom. Maybe it's better to have, your mom still there, but not as functional, but it's a lot to think about, I think. And at some point though, you start to kind of gain this normalcy because there is a natural grieving process. And I think it's inevitable at some point that you need to do this in order to accept kind of like things you found to be problematic, and you have to move on from there, like in a productive way. Because I think, our self-esteem is tied so closely to our sense of competence as physicians. And so, for us, like we need to kind of acknowledge like these things happen and like mistakes are part of like our job, because it's like, it's very difficult to be perfect essentially. And I think like effective practice of medicine, it requires like some sense of narrative competence. And so the ability to like acknowledge, to absorb, to interpret, and act on like, stories and kind of what people share to you. This helps kind of make it more humane and like be able to move like appropriately through like these difficult situations. Obviously, like, it's not surprising that like if you're going through things, if you get time off, that's really valuable. So as we move into this like era of like CMGs, venture capital, like don't expect more time off actually. And just like general coping strategies too, right? I think like there are a lot of things you can do personally, but I think being able to have a community is probably the most important thing. And I think you really appreciate the value of having a core of people who understand your situation, the struggle, and like the experiences just like to talk to. And it's important to remind yourself of the positive outcomes as well, because obviously you have many more positive outcomes than negative outcomes. And so like this had me thinking about different cases that I've thought a lot about over the course of the last 4 years, and decided to do some evidence-based kind of like medicine research as well. I remember I had this patient in downstate who like had an SVT. And so like we sent a trope, obviously it's positive, right? And cardiology's come down and they're like, admit to the CCU, start heparin drip. We're gonna cath this patient like soon. This is when downstate still had CT surgery. Good times. And so of course the cath was clean, right? But because it's downstate, they dissected the LAD. So this person got a stent because of this like iatrogenic like event essentially. And it's interesting because there's a lot of good research showing that people, SVT in general, these patients have low pretest probability for having coronary disease. And like you send a lot of troponins, there was like a 2019 systematic review that kind of like looked into this, and you get a lot of positive troponins, but like there's minimal correlation and association between a positive trope and like actually having CAD on cath, let alone having an occlusion, which is like what actually warrants, angio and stenting, right? This is like a retrospective analysis, but still I think the point, bears, where, it's kind of like an unnecessary harm that's inflicted on a patient because like we've pursued this diagnostic pathway. And it's interesting because like you can kind of extend this down into even end-stage unstable angina, right? And these are definitely cardiac patients, not just like the general OBS for ACS that we do, where routine PCI versus like selective, like, conservative management, there wasn't really a change in all-cause mortality. There's no statistically significant change in like the frequency of MI on like 6 to 12 month follow-up. And like there are more harms with invasive, procedure actually. And, we stress test a much lower risk population than this. And like going down into the ischemia trial, right? There's no difference between medical management and intervention in patients with like stable CAD, where revascularization is not really helpful. Like the real benefit of, I guess, I don't know if it's like a benefit, but like we do stress testing, as part of like our standard of care for these patients like who get OBS, right? They get serial EKGs, serial they get like a stress test. And like the only RCTs are stress testing in the ED, they demonstrate no benefit for the patient. RCTs in other patient populations have also demonstrated no benefit, but an increase in invasive procedures. So you do a stress test to basically do a cath afterwards. And like whether that means the patient has a better outcome is actually not really the case. I mean, the literature makes it pretty clear that stress testing results in net harm for our patients. And these are obviously like low risk patients actually. Like the sensitivity is like pretty low, the specificity is pretty low. If you end up doing the math and you kind of calculate it out, if you apply to a population with a pretest probability, like these OBS patients who you OBS for ACS, for every 1,000 patients we expose to stress testing, there's like 2 at risk for having an MI, and then the stress will pick up maybe 1 of them. And then for that 1 true like positive stress test, you get 150 false positives. And so think about all like the harm you do with all these unnecessary caths that can cause problems. People that are cath and they put on dual antiplatelet therapy for like no good reason, And so that ends up being a problem. You can extend that to syncope as well. I had this other patient, basically, this is my second year. She had this story that was like kind of like vasovagal, but she had some like cardiac risk factors. So, you put this patient on OBS, right? That's what you do. And unfortunately, they put this IV in. She was on tele for like 24 hours. Nothing happened as expected. And she developed this like phlebitis and developed like abscess at her IV insertion site. And so they're like treating her for like a MRSA abscess. And then she developed HCAP on like day 3. And then she became a code 88, got intubated, and then she was in the NICU for like a week. And fortunately for her, she left the hospital, but she was functioning very different, right? And this is all for like a syncope admission, which like, to be totally honest, was like completely unnecessary. And so like the question is like, who's actually at risk of developing like a malignant dysrhythmia? And there's some good papers. This one in particular kind of like shows like the people who have like an adjusted kind of like risk of developing like a bad rhythm, right? But if you look at like this graphic down here on the bottom right, you can see like the most common like dysrhythmia is like an SVT, which like SVT is not really a fatal dysrhythmia. And like you catch this like on day 2, right? Like your syncope OBS is for like 12 to 24 hours until you monitor and discharge the patient. But like here the patient goes into SVT like commonly day 2, day 3. And like the more like concerning rhythms, like basically if you should see the rhythm when you're in the ED, and when you put them on tele, you should see some kind of abnormality basically. Or, you have these various factors that like predispose you to having like a more malignant rhythm. But even then it's like in 30 days, right? And like you're obsing someone not for 30 days, you're obsing them for like maybe 8 hours, ideally 8 hours, so the hospital makes money, right? So you can churn through the patients. But like, the things that actually matter, right? Bottom branch block, QSC abnormalities, like a first degree AV block, ectopy, all these things, like that makes sense, right? But we generally obs people for syncope with like normal EKGs, stories that are largely like not concerning for cardiac, pathology. And so that's the question, like what are we really doing, right? And so I think this a lot of people in the department actually feel this way, but obsing someone for ACS and syncope incredibly low yield after a negative EV workup. Obviously, you modified this like your patient population that you like go to, so at a different hospital, different kind of like patient cohort. But even then, I think like, the same principles apply too, where you can effectively rule people out in the ED, like over like their brief stay for like MI and syncope pretty well, actually. Yeah, a couple more cases I want to talk about too. had this pretty ridiculous case when I was a second year, where this like 31-year-old woman came in with like an SVT versus like a rapid AFib. And so we gave her adenosine because it was just like so fast. The rhythm broke very briefly before she went back into being really tacky. And so we gave her 10 milligrams of diltiazem, no budge. Gave her like 20 milligrams with dilt. And this woman who's 31 with presumably no medical problems, like her pressure dropped. She became ashen. She became altered. And so we basically reversed this, like gave calcium, glucagon, push dose, epi, all these things. And eventually this patient, when we echoed her, right, she had like this incredibly poor EF. And so the big learning point here was like, when you rate control someone, be very cautious. And oftentimes when you rate control people without really having a good sense of why they're going fast, like this leads to bad outcomes. It occurs within the first like 1 to 2 hours of arrival, essentially. And the adverse events include like people need to be intubated, hypotension, cardiac arrest, needing more inotropic support, right? Especially if they have like underlying like sepsis, pneumonia, or heart failure. These people are kind of like high risk. And so always be mindful, because is the rapid rate the driver or like the bystander? Like, is this rapid rate harming like your stroke volume, or do you actually, are you just kind of going fast in general? And this is just like a pathology. And so it's important to like think about like what is actually causing the instability, and if it's the actual rhythm that's going fast, you treat it. If it's not, it's just like a bystander to, increase cardiac output for whatever reason it is, right? Then you have to be very cautious about what you do in that situation. We don't need to go over that's the thing. This is for D'Souza. And what was interesting for this patient was that like when she was hospitalized, so they looked at her labs, eventually she went to the CCU, she kind of stabilized, but then they found that she had like an AKI, she had leukopenia, lymphocytopenia, an elevated gamma gap, which basically you take like the total protein, you subtract that with like the albumin. And so like it was very, very high. And so they made the diagnosis that she had HIV basically. Actually, she had AIDS essentially. And we see a lot of these patients here at County actually. You can make a lot of AIDS diagnosis in the ED. And it's interesting because even before they had a sense of like HIV causing AIDS, like they saw that there was this increase in the levels of immunoglobulin, even though the relevance wasn't really clear. But they found this with like the B cell activation in vivo, suggesting a lot of viral simulation. And then, once you kind of like treat with heart, right, you have this decrease in immunoglobulin as well. And so a protein gap reflects like this abundance in like these proteins. And typically like here at County, like you should be thinking it's either multiple myeloma, some sort of malignancy, or it's HIV AIDS. And so this is a test you can do in the ED that actually changes people's lives, right? Clarifies an etiology pretty significantly. And so the world is yours. And so basically, rate control, don't mess with the compensating heart. I think it's good to echo people before you like rate control them or cardio rate them. Always assess skin turgor, figure out if they need the rate to support the cardiac output. And I would say get comfortable with cardioversion and also think about SML as like your friend. And then I think COVID made us look at the CBC and the diff a lot more carefully. And I think here too, if you see leukopenia, if your lymphocyte count's less than 1,000, especially less than 800, and you have this gamma gap that's elevated, like definitely get an HIV test. There are a lot of people that get admitted for like hypoxia who end up, testing positive for HIV because they have PCP. So like it's something to like think about. And then the last case is like just difficult like physiologic intubation basically. This is like my first CCT shift as a senior. This like young guy who's like going to like his first chemotherapy appointment, like he collapsed in the E-loading lobby. And so he comes into CCT just like screaming, I'm gonna die. How are you helping me? He's totally like, agitated. So we do like ultrasound, his RV is a little bit dilated, IPC plethoric, right? So we're kind of like thinking, okay, this is what's going on. His blood pressure is getting more and more soft. So he gets like 2 liters of fluids off the bat because nursing is like really aggressive about giving him fluid for his blood pressure. We're just like, no, don't do that, because I think, this is like RV dysfunction, right? So like be comfortable with this like spiral diagram. You've probably seen this multiple times, but when you give fluids, right, to someone who has a failing RV, it's not very good. This patient came in with like a blood pressure that was like kind of lower than their heart rate. And so think about the shock index in the situation where if your shock index is greater than 0.9 or higher, then like your mortality rises pretty dramatically. And these things give you a sense of the patient being very sick. And like threshold has to be kind of like faster to like start pressors or something else that's more important. And so like, this patient, ideally you start oxygenating because you can't get like a sat on really, high flow, whatever it is. You don't give fluid, you start them on pressors instead, because the fluid's only going to harm them more. And then when you intubate this patient, you should expect him to die, basically. So we intubated this patient and he immediately coded like pretty quickly afterwards, like within the hour, basically. This is like a study that looked at people that were undergoing like an emergent like pulmonary artery embolectomy for like PEs. And 20% of patients who were put under anesthesia had hemodynamic decompensation, which meant that they became hypertensive. That was refractory to like vasopressors, fluids, and they need to have CPR and then put on bypass immediately. So like about a fifth of these PE patients like died when they were induced under general anesthesia. And so like think about that when you're trying to intubate your next like PE patient or someone who has RV dysfunction, because these people are like waiting to like die basically. So understand the physiology, think about the shock index, always stabilize before you intubate someone like hemodynamically. And then if you need to intubate the patient, you know, it's the last resort, but like first pass success, it's really important. So I think like in summary, you know, you have to couple like deliberate practice with like following up on your patients. You know, this life will change you fundamentally, but it's important to like kind of remind yourself of like the positive outcomes. And then there's some various things that are important to consider, I think, just, you know, clinically speaking, so that we, you know, don't make the same mistakes over and over again. So just a little thank you to the people of this residency.
I have nothing to do with this.
It's a special place. I don't know if you guys will ever experience Bembe again, but it's pretty good. So yeah.